Today, we're going to be talking about the upper extremity, the biceps and shoulder in particular, and I'm joined by orthopaedic consultant Dan Rossouw from Total Orthopaedics in London. Dan, great to have you with us. How are you?
Yeah, hi. Thank you. Very good. Thank you. It's great in London. It's a bit rainy today.
We can tell from your accent that you're a South African. So do you want to give us a bit of background on yourself?
Yes. I qualified basic medicine in South Africa, but I've done all my postgraduate training in the UK, around London and the Northwest rotations, going out to Reading and working with, got inspired by people like Steve Copeland, who are great pioneers in shoulder surgery. So I now work at the Royal Free in London as an orthopedic upper limb consultant.
Right. And orthopedic upper limb, I mean, do you specialize particularly in just that area, or do you cover other areas as well?
No, we tend to subspecialize mostly now. Most hospitals, certainly in the UK, developed subspecialty teams. So I'm part of a 3-man upper limb team, and that's what we do, really. I guess it gets you better outcomes when you know what you're doing.
Well, one would like to think so, yeah.
Yes.
Where does Total Orthopaedics fit into the Royal Free?
So Total Orthopaedics is not really part of the Royal Free. We have formed this similar group of orthopedic surgeons, and Total Orthopaedics was designed to be a private service delivery group of surgeons that total, because we cover all parts of the body. So that's not just upper limb. Total Orthopaedics is amongst the 11 of us who belong to it, cover all parts of the body, spines, hips, knees, feet, ankles, and we hopefully offer a pretty comprehensive service.
And what's it like at the moment in terms of, I don't know, the backlog of patients as a result of the first lockdown and your ability to treat with the current constraints?
Oh yeah, it's been pretty challenging, because with the first lockdown, we stopped doing all elective operating. So there's been a massive buildup of people waiting for treatment. And secondly, it's been difficult when you have to operate, because it takes such a long time in the emergency situation, you know, wearing full PPE and getting people into beds and getting them nursed has been a challenge. It's been a real challenge.
Does that mean you get people out of hospital quicker in order to minimize the problems in hospital?
Yeah, we try to, but yeah, we've been doing that as a sort of status quo from quite a few years now. We've been reducing length of stay as part of a quality improvement for many years. So we try not to keep people in hospital anyway.
So if we move on then to your special area of interest, I feel a bit like I'm hosting Mastermind here, but I doubt there's any challenging questions I could put to you.
No, that's fine.
Shoulder's always a bit of a challenge, you know, for osteopaths, chiropractors, physios. I mean, I don't know about orthopedic consultants, because it's such a complicated joint, it seems to me, and so prone to injury. Well,
I mean, the reason I went into shoulder surgery is because it's quite a mysterious joint, and it is very, very difficult. It provides challenges, and it's like solving puzzles all the time. For me, you know, seeing somebody with an arthritic hip was pretty straightforward. Yeah, there were clear guidelines. What do you do with this case? That's it, boom, 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 and you do it. With shoulders, it's not so easy, because they all present in pretty much the same way and could have completely different conditions causing their symptoms. And the other part of it is true as well, that, you know, two people, as we were discussing earlier, might have the same diagnosis and be treated completely differently, depending on the interaction between your experience and what the patient's requirements are.
The trouble is as well, I think, everything I've read about special tests for the shoulder seems to indicate that they all tell you that there's basically something wrong with the shoulder, and it's very hard to pin down exactly what it is.
And the patient's already told you that when you've come in, you know, there's something wrong with my shoulder. And it's true that you can't rely on one diagnostic tool like a hip x-ray. You have to take the whole lot into consideration. You've got to listen to what the patient's telling you about the nature of the pain that they're having, or the dysfunction they're having, or the weakness. That's interesting. In shoulders, you can only have weakness, stiffness, or instability with pain. Those are the 4 symptoms. And the combination of those 4 symptoms gives you the vast array of conditions that you go through. But if you boil it down, there's very little that goes wrong. It's either unstable, stiff, it's unstiff, i.e. wobbly, or it's weak. And the combination of those things will tell you what's wrong with your patient if you listen carefully. And then you have to interpret your physical findings with the tests and come to some form of conclusion about what's going on. But that's only the beginning of it, because then you've got a fair idea about what's causing their symptom. The next big challenge is what you do about it.
Yeah.
And, the standard treatment has always been go from non-invasive to invasive, from minimally disruptive to massive invasion, depending on where your requirement lies from your patient and how severe it is.
Yeah. Well, one of the things that complicates things is when someone like yourself says there are actually 5 muscles in the rotator cuff, which was what came through in our email discussions before this.
Yes.
And perhaps you want to talk to us about the renewed anatomy of the shoulder.
Well, it's people are learning about shoulder muscles all day still, and you wonder, we've been studying it for so long, haven't we got it right yet? And as you say, we're now calling it the 5th muscle, and in fact, I'll tell you about another one. It's probably a 6th one. But the biceps tendon is what was referred to in this course as being the 5th rotator cuff muscle. And because of its function, when it contracts on the actual humeral head, it acts as a compressor, depressor muscle, and will help centralize the joint. And it's very interesting. If you see somebody who has a massive rotator cuff tear, the effect on the biceps tendon is that tendon hypertrophies dramatically, from being a 5 millimeter diameter tendon to a 25 millimeter diameter. It can sometimes look very like a supraspinatus tendon. And the body is an interesting and very functionally self-regulating organ. And particularly muscles like bones, if you stress them, they hypertrophy, they get bigger. And you can often think that this biceps tendon is trying to replace the function of an absent supraspinatus, for instance.
Right.
So it functions like a head depressor.
How effective is it at doing that?
Well, not brilliant, but every little bit helps in the shoulder. When you're on an edge, that doesn't take much to change a functioning to a dysfunctional shoulder. Or go the other way, from somebody who's pseudo-paralytic and can't lift their arm, with a bit of training, a bit of rehab, correct bit of physiotherapy combined with pain relief, and suddenly the little bit of extra that you get from the strengthened up muscle helps the shoulder suddenly become functional again. So it doesn't take very much to tip the balance of a dysfunctional, painful shoulder into one that's working. And that's probably why people will, sorry, I'm carrying on. But that's why it's this thing about trying to get a bit of rehabilitation going early, even in the face of what seems to be a disastrous situation on an MRI scan. You can often get people just returning to fairly normal function with much reduced pain without doing anything. Yeah. We'll talk about that a bit later when we talk about treatments.
Well, I was just about to say, the long head of biceps particularly seems to be quite either involved or causative or whatever in shoulder problems. Is that because it penetrates the capsule? Or?
Yes, it's in an unfortunate position because it sits in an area which is also occupied by the subacromial bursa, which is also occupied by the weakest points in the rotator cuff. So the only thing that doesn't usually start up at that point is arthritis, but all the other pathologies we have start up in the same region. So it's a pretty bad area for generating shoulder pain, and it's also pretty bad at being specifically diagnosed, because generally, if you ultrasound the general population, that area where the biceps pain is in your shoulder will have a bit of bursitis, a bit of tendinosis, possibly a partial thickness pasta tear, and differentiating which of those is actually causing the problem may be partly responsible to why there's such a frequent diagnosis of biceps tendinitis. It's a very common diagnosis. Most people say, I've got a bit of biceps tendinitis. Why? Well, it's tender when you press it and it hurts in the place of the biceps, and you rub it and it hurts, and you move the biceps and it exacerbates the pain. But that could be true for most of the other conditions that we were mentioning as well. But it is a vulnerable tendon because it is a biarthrodal tendon. It crosses 2 joints, which means there's a lot of wobbliness in the system, if you want to call it. That's not a scientific word, but you know what I mean. Yeah. And The tendon also moves around a sort of 90-degree bend a lot of the time in a fairly narrow little groove. So you have the effect of I always consider sort of the rope climber's rope over the edge of the cliff. There's got to be a bit of scuffing and rubbing going on there. And it's also a reasonably avascular area. So the tendon is subject to fraying, to damage, and it's also got all the other things that are going around it there. So the bursitis and the rotator cuff insertions are all converging on that point where the biceps leaves the joint.
How common do you think it is for the biceps tendon to become displaced from its groove?
So, but in degenerate tears, it certainly is. And the thing that holds it in place in normal anatomy is also a fairly mysterious structure in the rotator interval, called the biceps pulley. And it's called the biceps pulley, and people consider that just to be a little bit of tissue across the bicipital groove to contain it. But it's actually a much larger and more complex structure than that. It involves the coracohumeral ligament, which goes from the coracoid to that region and forms part of the roof of the biceps groove. It involves the subscapularis insertion and some of the cross fibers of that. The transverse ligament at that area forms part of the biceps pulley. So it's a fairly complicated area to try to keep the biceps tendon in place. And that tells you that it must want to pop out every now and then. And some people have congenitally narrow grooves, so there's more pressure on those soft tissue structures, and they often fail, particularly the top end of subscap. If that fails, that's usually a pretty strong indicator that the biceps is going to start subluxing out. And it starts from the top downwards. So it'll start just at the top end of the groove, and as the subscap fails and the biceps pulley structures fail, it becomes more and more, and it's a sort of postage stamp effect. Once it goes, it goes. And it could be very painful, because that's a very painful sort of thing to happen.
When it does become displaced, by certain techniques, we can put it back in the groove. Will it then recover fairly readily, or does it need further surgical assistance to keep it there?
Yeah, it won't stay on its own, because the forces that have got it to be coming out will still be there. And there is, just as around that area, there is this interesting condition I heard about, and I've seen only once subsequently. It's a rare condition, but it's called biceps entrapment, where if you fully abduct and flex forward, so you go into an adducted overhead flexed position, you're internally rotating the humeral head on the glenoid, which means you're taking that biceps pulley area right onto the glenoid and then moving it backwards. The biceps tendon can, in some people, sublux into the joint and get entrapped and locked between, like a locked bucket handle tear of a meniscus. Can get itself entrapped in the joint. Right. And that was an interesting thing to know about, and it apparently presents with posterior shoulder pain. So it's one of the rare causes of posterior shoulder pain, this condition. And there's a test for it. It's like an O'Brien test, but going further high in the air and internally rotating a bit further, and there's a clunk and your shoulder gets stuck. Now, that just served also to remind me to think about what happens to the biceps tendon when the arm goes into all these peculiar positions. We always think about the biceps with the arm in the anatomical position and the biceps is running downhill. Sometimes it's running uphill. So you've got to think about what you're doing with the biceps when the arm is elevated or internally rotated. Its position relative to the subscap with the rotator cuff muscles, to the labrum, to all of those things changes completely. So there's a lot of stress on that area. And, we were saying, will it continue to sublux? Yeah, it probably will.
Right. So what's the technique or what is the problem that you see most of in clinic? My biggest problem is trying to work out whether this is bicep problem or, the diagnostic conundrum that we're in, what is it? And it's difficult because your special radiological examinations don't often help you, because they come up with, there's all three of those, and we don't know which one's causing the pain.
So you have to try and work out what's the pain generator. The commonest clinical condition I see there is this fraying and degeneration of the biceps tendon in the sort of middle-aged to elderly population who are maintaining fitness by going to the gym and doing things and playing tennis, and it becomes painful. And there's a school of thought, you know, the French are very happy to cut the biceps tendon because they don't believe it has much in the way of functional in need, necessity. But when people come along with this pain, you say to them, look, I'm going to cut your tendon and that'll take your pain away. It sounds counterintuitive. But this is a process that happens naturally when people spontaneously rupture their biceps tendon. It's therefore, that happens because of a degenerating painful tendon pre-existing. And finally, the last little strand goes and there's a catastrophic episode, but it settles and it becomes the pain that was there before usually goes away.
And I presume that, I mean, that catastrophic episode is what leads to the Popeye sign, which is much talked about, although I personally have never seen it. We've got a picture of it here.
Yeah, let's have a look.
Popeye sign.
So it has to do with the anatomy of, I don't know if you can bring the picture up.
Slide number 4, Justin.
And I'll just talk over it. The long head sits anterior to the short head, and as it ruptures at the top end, the elasticity of the muscle pulls the muscle belly down, and from being a fusiform shape previously, it becomes a ball, like a cricket ball. And it's the size usually of a cricket ball, maybe a table tennis ball. And it can be quite disconcerting. There can be a lot of bruising. And I guess I spend more time reassuring people when I see this happen, that it's not dangerous, not going to kill them. It's not something that's an emergency. And quite often, if the patient, as you could see, was probably a fairly low demand patient, you try and convince them not to have anything done at all, which is really difficult sometimes because expectations are if you've torn something really bad, you want to get it fixed. Actually,
you're saying in France they would cause this problem. They would cause a Popeye sign by cutting it anyway.
A lot of the time, if you are arthroscoping somebody for shoulder pain, and because of the difficulty in diagnosis, you might be thinking that it's primarily an impingement or a bursitis tendinosis that you want to do a decompression for, and you scope them and you find that there's a very degenerate biceps tendon. And in that instance, I'm often, when I'm not certain, I would consent somebody for a biceps tenotomy. You just cut the tendon near its root on the glenoid and allow it to drop down. And patient, sometimes if you haven't told them about it, they're quite unhappy because they've suddenly got this big ball in their arm. But it takes the pain away, and functionally they are pretty good. And for the non-manual worker, just normal Joe Soap who works in an office as a slightly, a lot of gray hair like myself, you can function perfectly normally.
Yeah. How much does it affect range of motion of the arm?
So range of motion, not at all, because you're not affecting any of the joints, but the power in flexion usually drops by about 20%. But it recovers because you the short head and brachialis both hypertrophy in response to a bit of physiotherapy, a bit of help from training, guided osteopathy going along just to get things moving and keep it there, getting rid of the swelling, getting rid of the pain. 2-3 weeks down the line, if you measure their strength again, it's probably only 10% down, and within 3 months you get back to normal equal strength.
Dan, I've got a few questions for you from the audience, if I can take those now.
Right.
Jonathan says, is there any reliable way you can specifically diagnose the biceps tendon as the problem and not other areas of the shoulder? For example, the other muscles of the rotator cuff?
I can't. I've tried, and I'm never 100% certain that this is definitely bicep. So clinically, you can palpate the bicipital groove. You can try and do forced resisted flexion. You can strengthen the muscle, do the speeds test, do the other tests which we traditionally do, but it's very difficult. And as I said earlier, if you were to rely on your special investigations such as ultrasound, which is probably one of the better ones for this, unless the ultrasound says there's no bursitis, there's no tendinosis, but there's definitely inflammation around the biceps tendon, then you're pretty good on the diagnosis. But in my experience, every ultrasonographer comes along and says, no, hang on a bit, there's a bit of bursitis, there's a bit of tendinosis, and there's a bit of biceps tendinitis. Sure, I'm not certain if it's desperately important to make that distinction, because I think our first line of treatment is going to be, rest, gentle mobilization, a bit of friction, a bit of ultrasound, a bit of mobilization, getting it all going and seeing what happens for all three of those conditions. So I think you're brave if you can be certain that it's biceps tendinitis and not one of the others.
Yeah.
Of course, the biceps sheath communicates with a joint, so it's all one space. So if there's any problem within the joint or a bit of an effusion, it'll go down the sheath, and so there might even be a primary problem in the joint itself.
Yeah. Moving on, Vlad has asked or has said that he's seen more supraspinatus tendinopathy as diagnoses on case histories than he cares to remember,
yes,
particularly during his time working for the NHS. And he's asking whether it really is that common, or is it just the catch-all scapegoat diagnosis?
So I think it's, again, the problem of you making a diagnosis what the ultrasound tells you it is. And certainly if you send, and I agree with him, I can't ever, I think I've probably seen 2 this year of people that I've sent for an ultrasound of their shoulder, query cuff tear, query tendon problem, that come back without tendinosis and bursitis. They always come together. So it's almost a pre-stamped report that goes on the ultrasound report that says this is a tendinosis and bursitis.
Tendinosis of supraspinatus in particular.
Supraspinatus, yeah, it's usually the supraspinatus. And when you arthroscope these people, the tendon itself usually looks reasonably good. So I'm not sure what the appearance is on the ultrasound that makes them do this. And when I look at the ultrasounds, the pictures themselves, the tendon is a little thicker than you expect it to be. But I'm not sure if that sort of counts as just an appearance with bursitis on top of it or not.
Right. You've intrigued Bill. Bill says, what's the 6th muscle of the rotator cuff?
Okay, so subscap minor is, just for cut a long story short, because then I think that the lower 1/4 to 1/3 of subscap is embryologically a different muscle. And although it's part of the subscapularis complex, when you operate on these muscles, you see that the upper 2/3 of the subscapularis has a muscle belly, which then turns into a very nice aponeurotic fibrous tendon and then joins onto the bone. And the bit right underneath seems to be muscular all the way right onto the bone. And somebody's had a look at this now, and they reckon that it's embryologically slightly different from the rest of the subscap, because it's got a different, that portion, they've got a slightly different nerve supply, and also looks different. So yeah, so there's the 6th rotator cuff muscle, subscap.
I wonder if that actually makes any difference to our approach to rehab and things like that, or even your approach to surgery, does it?
No, not at all. It's just, it's unlike the teres, where, there's a teres major and minor, they've got very different functions. The subscap, that little bit does the same job as the rest of it. And it doesn't, its nerve supply is from the subscapular nerve, so it's all absolutely the same.
Yeah.
We just incorporate it in if you operate and you're doing an approach to the shoulder, you divide it as you would do the rest of the muscle. But who knows? Maybe somebody will come up with something new one day about subscap minor.
You mentioned a low demand patient earlier on, and Eli wants to know how you define Eli or Ellie wants to know how you define a low demand patient.
Okay, I guess it depends what you are yourself, because everything is relative to everybody, and an elderly patient is getting older and older for me now. But I guess low demand is somebody who will perform mostly what we would call activities of daily living. So getting dressed, eating, drinking, shopping, driving, without exerting or having a physical occupation which involves lifting heavy weights, repetitive maneuvers, manual labor. sport, which puts you at your arm at a higher demand than it would normally do for your activities of daily living. So I guess maybe low demand might equal sedentary, might equal non-sporty, might equal non-manual laborer.
Right. Okay. Something a bit more specific for you. Phil says he has a patient who had an ultrasound diagnosis of an inflamed supraspinatus tendon in February this year.
Yep.
The patient, of course, then disappeared into the ether because of lockdown and has reappeared this month. Apparently, he's a gardener who does lots of hedges, and the condition is much worse now. Would steroids be a good idea for him?
Yeah, in short.
Good. And I think somewhere in the slides I was given some time ago for this presentation, you had something about sort of the limited applicability of steroids. Was that?
Yeah, so this is an interesting one. And I think this has been driven by insurance companies rather than anybody else, because they've put a limit on the number of steroid injections one is remunerated for by an insurance company. But there is also some evidence that repetitive steroid weakens the myofibroblasts and myofibrils of a muscular tendinous structure. And they did some work on this in Oxford when they were doing the Seesaw trial. They took biopsies of tendons and linked to, they were able to link the number of steroid injections to apoptotic changes. Apoptosis is a great word I learned recently. So I had to use it.
Yeah.
But so there is a thought that there are too many steroids, and there is a concept of too much steroid, but what the number is difficult to quantify. So what I tend to try and, just as a guide, I would say 3 injections a year is probably enough. Then I wouldn't worry too much about the effect on the tendons. And you can repeat that year on year. So in 10 years, you could have 30 injections. I don't think that would harm your tendons or your muscles at all.
Right.
It is, after all, a pretty natural substance we're injecting. It's just in a higher concentrated form.
Amanda's asked us about the Popeye sign, or asked you about the Popeye sign. She says she's recently seen a patient with that sign and explained that it's not painful, and the patient can function. There may be no intervention needed, but Amanda did suggest that they speak to a GP to see if they want to do further investigations or referral. Is it totally unnecessary to investigate?
Yes, absolutely. I think you're wasting your time doing more investigation. That's one of the signs which is very specific and very sensitive. Right. So Popeye sign, the times when people worry about it and when I've been asked to do something about it is for people who do modeling or are worried about what they look like on the beach. Not at the moment, because we can't go there when it's the middle of winter, but you know, the physical appearance.
And then this is the United Kingdom. We don't go to the beach here.
I know. Yeah. For me, Christmas Day is a braai on the beach, you know, and that's just not on here. However, so it is a real thing. People do have body image problems with the Popeye sometimes, and that it would be an indication to do something. And I've had 2 or 3 people who have said, look, I know it's not hurting me. I just don't like the way it looks. There is sometimes also a very sort of moderately to mild achiness that happens in the muscle belly because it continues to be innervated and it wants to contract every time because the nerve impulses are being sent down by the brain to move when you bend your elbow. Yeah. So there can be a bit of dragginess and a bit of discomfort in it in the longer term. You've got to weigh that against an operation which is going to take a tendon that's so rotten that it's already ruptured itself and try and get it to strengthen up and rejoin somewhere. So your chances of success are poor to start with, and it's surgery which you don't really want to have if you don't need to.
And I guess right now that would be very much classed as elective surgery since it doesn't impair function dramatically.
Well, no, not really. I mean, if it's an injury and a sudden onset, and for instance, if somebody had a bad sort of body dysmorphic reaction to that thing, I would offer them a repair. With biceps, I mean, this is a fairly important thing. If you, both with the distal and the proximal, we'll talk about the distal biceps later, but certainly proximal. If you leave it too long, you won't get it back. The ability of the biceps tendon to scar down, hunker down, and stay where it is dramatic. And after 2 weeks, 14 days after the injury, you're on a loser to try to actually reattach that muscle or mobilize it sufficiently to put it back somewhere sensible.
Mm-hmm.
So there is, with biceps tendons, both proximal and distal, there is a window of opportunity that if you are going to do something, you need to get on and do it smartly.
Right. You said we're going to talk about the distal biceps, but we've got so many questions coming in. We might not move on to that. I'm not
No. Well, let's stick with proximal for the time being.
Angelica says, how can you help stabilize the subluxed biceps tendon? And is that important for rehab?
I don't think you can do it without surgery, is my honest opinion, because once it's out, the forces that have pulled it out have beaten and destroyed that biceps pulley we were speaking about earlier. And without that restraint in place, it's every time you flex your arm and internally rotate, it's going to come out. So I think you're on a loser if you're trying to stabilize it via non-surgical means. Please tell me if there's a method that anybody knows about, but it doesn't seem logically possible to me for that to happen.
Would that stabilization, surgical stabilization, involve nailing the existing structures back into place, or would it mean grafts?
To be honest, I would probably do a biceps tenotomy and tenadese it, because that is a reliable way of dealing with it. And what you were describing, trying to recreate the biceps pulley, it's a very specialized structure. Once you start operating and all you get is scar tissue.
Yeah.
So I would sacrifice the function of the long head of biceps in the joint, cut the biceps tendon, and just do a straightforward tenodesis outside.
Right. Now,
tenodesis is an interesting thing I could talk about, because there are many ways of doing that surgically. Traditionally, you try reattach the tendon to the groove, the base of the groove, by drilling a hole and putting a variety of screws in. A newer way, which I've started doing recently, is to actually take that tendon and put it onto the conjoint tendon from the coracoid. So you're just moving it a little bit medially, and you're recreating what the gibbon apes have got, an origin of the short and the long head from the same place. And that's a soft tissue procedure, which is less painful and recovers quicker.
Interesting. I'm talking about the apes. I do remember there's a very well-known osteopath who deals primarily with shoulders, and he once showed in a course I was on an illustration of the way that the scapula has evolved as humans have evolved from apes, and actually the whole angle of the shoulder has changed because of the lack of overhead movement that we need.
Yep. So the great apes have got a much smaller scapula, and it's much more ventrally placed, dorsally placed, sorry, and higher, with the glenoid facing more in an open direction. So they can much more easily just elevate the arm and hang from it. So it aids brachiation a lot.
Yeah.
But their biceps tendons have a different, that sometimes don't have a long head of biceps going through the joint. It attaches onto the humerus.
I don't know what the background to this question is, but Nick has asked whether there's much integration with other surgeons or other therapists regarding related areas of the body prior to surgery.
Related to other areas of the body prior to surgery.
I don't know whether he's thinking about the connection of the shoulder with the neck or the elbow, or general function of the body.
Yeah, I'm not sure about that. I mean, we do try.
I mean, Nick, if you want to send us a bit more information, then we can perhaps delve into that a little bit further. Visby says, as a source of symptoms, which gives more pain or impeded mobility, muscular tendon damage or labral damage? In other words, how significant is the labrum as a source of symptoms that needs correction?
So yeah, it is pretty important. It is a nerve-rich structure, and if it's ruptured, the symptoms are mechanical usually. Associated with clunking, and they can be quite severe. I suspect that if your question says which is more severe, I would suspect the labral injuries are probably the ones that I see more commonly that don't improve. whereas muscular tendinous injuries can heal themselves pretty well. So if you get an intrasubstance tear of the biceps or a tear at the muscular tendinous junction, within 3 months, they'll probably go away. And there the therapies have an important role to play. The labral tears that we get, the slap lesions and the anterior labral injuries, they tend not to resolve themselves, and they tend to be the ones that continue to cause pain and continue to cause pain and continue to cause pain. And the problem is, it's not often a very physical disability, and it's often a very moderate to mild discomfort, which you can avoid by not using your arm. And so they tend to take a long time to get sorted out. They're the ones, you know, during lockdown, which would get put to the back of the queue.
Dan, we've got less than 10 minutes left. I wonder if we could perhaps move on to the distal biceps, because
okay.
Perhaps it's a little bit unusual interest to people.
So there is a slide which shows...
Yeah, slide 15, I think, is quite a useful one. That's the one which shows what the damage might look like and what the
And it also tells us a little bit about the anatomy. So the distal biceps inserts into the radial tuberosity. So it has two effects. The biceps has an effect of flexion and also supination, because it winds itself up around the radius when the radius is pronated, and then as it contracts, it supinates the arm by untwisting the radius. So those are two important things. And until power screwdrivers were invented, that was one of the sine qua non indications for repairing a distal biceps, was the fact that if you had a carpenter who had to put screws in with his right hand, he'd need a distal biceps, and it would be a very strong reason to repair his biceps, to give him back his supination power. So that doesn't exist anymore, because now we all get these battery operated screwdrivers and they work for us. But the tendon distally usually ruptures at its attachment to the bone, so that the actual tendon remains intact. It's not a tendon rupture, it's a failure of the bone tendon interface. So it's a periosteal avulsion with the rupture of the Sharpie fibers which are in the bone. And it's quite nice that it does that, because you can see it's like a sort of plug end of the tendon. You can see exactly where it's got to go back on, and it shows you very nicely where to put it. The rotator cuff tendons sometimes don't fail like this. They fail by the whole thing, the whole tendon itself becoming attenuated, cracking up, becoming little fibers independently, which then all tear. So it's a mess when they rupture. But the distal biceps comes out really nicely. And the reliable test is the thing in the middle, which is the O'Driscoll hook test. And it's really nice to do. And please, everybody, do it on yourself while we're sitting there. You bend your elbow to 90 degrees, and they take the index finger of your opposite hand, and you'll feel there's a rope in dig it in deep, dig really deep into your elbow. There's a rope. Yep. And you can hang a coat hanger on that rope. If you had a coat hanger, you could hang it. Not recommended. On it. Yep. The rope that you're feeling is the biceps tendon. Now, if you can't feel it, do it with modified resistance to flexion. So ask the patient to resist against flexion and then try it again, because it might just be hiding away in a bit of fatty tissue. Not that I'm saying anything here. And if you still can't feel it, that is a very, very, very reliable test that the distal biceps has ruptured. It's more accurate than an ultrasound and an MRI, in my experience.
And that reverse Popeye sign, is that reliably there?
Reverse Popeye depends how soon you get it. In the acute stage, it's pretty reliable, and obviously the muscle belly jumps up and rather than going down, but it disappears fairly quickly. I mean, by within a month or so. So sometimes, if you get a delayed presentation, you might not have as much of a reverse Popeye as you would have with a long-headed biceps rupture. Right. And I'm not sure why, but it's not as reliable. It's there in the acute phase.
I don't know if we can bring it up, but the next slide was about distal biceps rupture, and it was an MRI with FABS protocol. I've not heard of FABS protocol before. What's that?
The FAB. There was a picture of it on the previous slide on the left, where you go into flexion at 90 degrees, abduction. You have to fully supinate the arm. That's the F, and I'm not sure what the B is for, but it's one of those flexion, abduction, supination,
Right, okay, so
something. It's a position, but you're lying with the arm on the head, and you supinate, and then you do the MRI of the elbow in that position.
Yep.
So that clearly puts the biceps under some tension.
Gotcha.
And with it supinated, it should give you a straight line from the radius right down the arm, and it gives you a very straight line running down on the MRI scan, which shows you the biceps is intact or not intact. And I think the picture showed it quite well. Yeah,
I'm not sure we can bring that up, but the pictures will go out in the handout, which we'll make available after the show. I wonder if the B in that, I wonder if the B in that just is part of abduction.
Yeah, maybe it was an AB abduction. Yeah. It's important to do that, because if you just ask for an MRI of an elbow, normally you get these axial images, which don't mean very much. But that gives you a longitudinal picture of the actual tendon as it goes onto the radius, and you can really see it well. Right. So even so, MRIs and ultrasounds in the distal biceps can lie. There's a very thick, tough sheath around the tendon, going down onto the tendon through the forearm. And that sheath can resemble a tendon, especially if it's filled up with blood. So your Popeye sign is better. Hi, Claire. I
don't know why I've got Claire Short showing on my screen, because she shouldn't be there, but hopefully somebody will get rid of her in a second. I don't mean that in literal sense. We were talking about MRIs a second ago, and I've had a question from Rob Shanks, who is one of the osteopathic MRI experts. It's nothing to do with what we were talking about with the distal biceps, but Rob has a business called Go-To Imaging, and he's a fount of all knowledge on interpreting MRIs. But in this case, he's asked about what about attaching the long head to supra and subscapularis? He's heard of that being done before.
Yes, absolutely. As a form of tenodesis. So you can take you've got choices of lots of muscles. I'm just using the short-headed biceps now as my go-to muscle. All you want is to anchor it somewhere and for it to help with the suppression. So I'm just thinking now that he said that, the benefit of this technique that he's described would be that it would then also be a suppressor of the humeral head if you've got a weight in your arm or you're doing forced flexion. So not a bad thought, but there's no harm done in that. The trouble with supraspinatus is you don't want to put any bulk into the subacromial bursa, which you would do if you did the supraspinatus attachment. Going back to my point about the weird positions the arm goes into when it's not in the anatomical position, and we mustn't fall into the trap of thinking about function in the anatomical position. You've got to think about what happens when you put your hand behind your back or scratch your head. Doing that will completely change all those relations that we normally think of. And so you've got to be a little careful about where you put things. But subscap, I can't see any reason why not to do that. Maybe subscap minor. Yeah.
I don't have time to ask all the questions which have come through, but if I can put one very quick one to you, well, hopefully a quick answer on this. Morag says she's seen two ladies with acute spontaneous explosion, exclamation mark, of supraspinatus calcification. Yes. Is there a conservative management option for that rather than surgical?
Well, calcific tendonitis and supraspinatus is very variable, and it can be absolute agony. So much so that you're giving people pethidine, or it can be a moderately mild condition. Now, I'm anticipating what she's saying is that it's the acute, really bad one. Emergency-wise, steroid injection with local anesthetic into there will provide relief for 4 to 6 hours, and maybe a little bit longer if the steroid works, because the generator of pain in that situation is inflammation. That calcific material, when it forms acutely, is incredibly inflammatorogenic. It's almost as good a word as apoptosis. So the steroid will help with that. And that might be enough to get them through until the body starts sealing off and fibrosing around the calcific material and stop it generating the inflammatory reaction. But oftentimes, within a week, people are not sleeping at all, using vast quantities of painkillers, and you do an operation on them, and before they're actually out of the recovery area, they say, oh God, thank God my shoulder feels better. You just decompress. It's like draining an abscess. It is a calcific abscess in the tendon, and you drain the abscess, the pressure goes out of it, the inflammation goes, and they feel better almost immediately. The other group is the group that tolerates it. It gets sealed off and it lives in the tendon and can be completely asymptomatic. So you've got to be a little careful when you see calcium in a tendon and shoulder pain. They may not be the cause and the effect.
Dan, it's been a great pleasure talking to you. Thank you. I'm very grateful for you giving up your time. We have now run out of time, so I shall let you get back to your no doubt busy life, doing shoulder surgery and to your Jack Russells. And hopefully we'll get a chance to talk to you again sometime soon.
Yes, I'd love that. Thank you very much.
Thank you. Our pleasure.